All right, so we're looking at page 28, starting with objective number 1 of the digestive system. Kind of visiting, again, those cavities we talked about at the beginning of the semester. The peritoneal cavity or abdominal pelvic cavity is a name for the digestive region. So this is below the diaphragm to about the level of the pelvis, that region of the body. So the membrane that lines the abdominal cavity or the peritoneal cavity is called the parietal peritoneum. And then it folds back and covers the organs of the abdominal cavity, and that's what we call the visceral peritoneum. So the digestive tract is not sterile, right? We bring food into our mouth, it enters the digestive tract, comes down the esophagus, into the stomach, through the intestines, and out the anus. So it's not sterile. There's lots of bacteria when you get to the lower part of the small intestine, lots more bacteria to help digest. The colon is full of bacteria. So if there's a break in the digestive tract, that non-sterile bacteria-laden material ends up in the abdominal cavity, in the peritoneal cavity, and causes major infection. And the result of that is called peritonitis. So peritonitis is inflammation of the membranes in this cavity and infection. So what are some things that can cause a break in the digestive tract? What have you heard of? How about an appendicitis, ruptured appendix? You've heard of ruptured appendix before? That's the lower part of the digestive tract. That bursts, causes infection. Peritonitis is the side effect of that. So high doses of IV antibiotics is necessary to prevent people from dying from that, because years ago, before we really knew and had good quality antibiotics, people died from ruptured appendix. Perforated colon, because some people have diverticulitis. As we age, we get little pouchings of our large intestine. It becomes inflamed, bursts, people die of that. How about a colonoscopy, where the lining as we age gets thinner? Someone has a colonoscopy, the doctor breaches that lining, breaks through that lining, peritonitis. I had a student actually in general A&P that went in for a routine colonoscopy. He was over 50 and they ruptured his large intestine and he was in the hospital and had to get a colostomy while that repaired. So pretty big deal. Ulcers can rupture. If we let ulcers go long enough, they can rupture the digestive tract and cause peritonitis. So very, very serious condition. So we have to look out in our patients that they're not getting impacted, because when the bowels get full of stool, it works its way back up. There have actually been cases of people spitting stool because they're so backed up. So when we're in a healthcare environment, we have to make sure our patients are clean in the tract. Things are going in and they're coming out the other end. We have to pay attention to that bowel record. If you're working in the nursing home or you're working in a hospital, that should be one of the first things you look, or not first, but one of the top key things you look at when you take on a patient is when was the last, what are their vital signs, obviously, but when was the last time they had a bowel movement? Because oftentimes that gets overlooked. And they're embarrassed to say something. Some people don't like to tell you they're constipated and they need, a stool softener. So they just kind of suffer quietly. So it's our job to ask them about this stuff and make sure that tract is moving. Otherwise, you keep throwing food in, there's nothing coming out the other end. It's going to burst that tract. So peritonitis. The greater omentum is a fatty apron that attaches to the bottom of the stomach. So this is the stomach here. Here we can see the stomach here. So the greater omentum has been cut in this diagram, and it lies over the digestive tract. So it has lymph nodes in there, it has fat in there, and it just acts as a protective, kind of insulating covering over the abdominal cavity, because it's not protected by bone. It's kind of just out there and exposed. So it just has a protective function. I know someone who had a relative who had abdominal surgery, and they had to lift up the greater omentum to do the surgery in the abdomen. Then when they were all done, they forgot to bring it back down. They left it all tucked up under his diaphragm. So he was having trouble breathing after surgery, was in a lot of pain. It went on for weeks before they went in and said, well, let's do some exploratory surgery. Something went wrong, obviously. They went in and found that greater omentum all stuffed up under his diaphragm. And they had to remove it because it was damaged then. So, just simple anatomy that we can forget about that plays an important role. So we'll see that on the cadaver. We're going to go on the cadaver and look at some of these digestive structures. The mesentery is what connects the different abdominal organs together and holds them tightly intact. So we can see in between the intestines here, it's hard to see, but there's mesentery that, on this next slide here we can see it better, that holds that intestines in place. Otherwise our intestines would kink. You know, if they were just kind of flopping around in there, you know, they're pretty long. Our intestines are like 21 feet, I think, something like that for the small intestine. So if we're trying to stuff that all in this abdominal cavity and we're pushing food through there of different, you know, consistencies, we could definitely have a kink or a twist and prevent flow. So the mesentery holds everything in place. And there's blood vessels that run through the mesentery. And what blood vessel do you think? What blood vessels run through there? Yeah, superior and inferior mesenteric arteries. Yeah, so that's where that name comes from. So that's just that yellow connecting material. All right, then if we look down at the histology, looking at a microscopic view of the digestive tract, the inner layer is always called the mucosal layer, just like we saw in the respiratory tract. So what's in contact with our food is the mucosa. And the mucosa is made up of, what is it? Do you remember from the tissue lab many weeks ago? Tall columnar cells, so simple columnar epithelium. We find that lines the digestive tract. Once we get to the stomach and down, it's simple columnar. So that's what, if we look up close here, I can zoom in a little better. So this layer here is so the white is what is in contact with the food. And this is unlike the respiratory tract. This looks kind of squished, the luminous squished, because we know that when there's not food in the digestive tract, it kind of, you know, collapses in on itself. And then when we fill it with food, it stretches out a little bit. So simple columnar epithelium lines the mucosal layer. Then we have the submucosa, which is just the kind of connecting tissue between this and the two muscular layers. So these two layers, there's two sheets of muscular tissue called the muscularis, and that's smooth muscle. So if we looked at a slide of the muscularis, we would see that it's those thin kind of tapered cells without striations. That smooth muscle that makes up the two layers of the muscularis. And then this outer layer is just, again, connective tissue, holds it in place, and that's the serosa or adventitia layer. And if it was still connected to the peritoneal cavity and still in the body, then we would call that layer simply the visceral peritoneum, because it lies on the outside of the organ. So if we take it out of the body, we call it the adventitia, like if we're looking at a microscope slide. But if it's in the body, then it has a reference frame, then we call it the visceral peritoneum. So they're one and the same. But if you're looking at a slide, you should call it either serosa or adventitia. So digestion begins in the mouth. So if we start here, we're looking at, God bless you. So if we're looking at this side view here again, like we saw in the respiratory system, now we'll just look at those parts that are related to digestion. So we're going to focus on the oral cavity. So you have the hard palate. Here, that's the bony portion. Soft palate that ends in the uvula is the back portion that's non-bony. And that is the oral cavity. I think you're definitely allergic to something in lab. So the oral cavity is separated from the nasal cavity by this palate, right? So some babies are born with cleft palate, and they have mixing of food between the oral cavity and the nasal cavity. Did I show you a picture of that yet? It's important to understand that, because you're going to hear of people, or you may even know of people that have cleft palate. Maybe you've seen what they look like after it's been repaired, but this is what it looks like when they are babies before they have the surgery. That hard palate never formed. So the oral cavity and the nasal cavity are combined. So feeding these babies is a challenge, wouldn't you think? Trying to get that, nobody wants food in the nasal cavity, right? So they use special bottles and things to feed them until they have their surgery. Now here in the United States, most often kids, 100% of kids, because we have, healthcare for everybody, will get a repair surgery. But over in developing countries, when someone's born in a village over in Africa, they might not have access, to a doctor and, repair. So they have this thing called Operation Smile, where, oral surgeons volunteer their time to go over and do surgery for these kids. So after it's been repaired, then, it looks like that as they get bigger. So it's kind of nice. Then we look at the uvula. We already mentioned that. When we swallow a bolus of food, this uvula will push back against the back wall of the nasopharynx to prevent that food from going up into the nasal cavity. But obviously, if we're in the middle of swallowing and then you cough or laugh, that uvula is not pressed back and then food comes up into the nasal cavity. Or forceful vomiting, we're not making that swallowing action when we're vomiting, food comes up into the nasal, or vomit comes up into the nasal cavity. So the tongue is this muscular structure here at the bottom of the oral cavity. So it helps to break down our food by moving the food around in our mouth, exposing it to saliva, getting it into a soft ball called a bolus. And then when we're ready, we swallow. So people that have had a stroke that don't have good control of their tongue and the swallowing muscles end up choking. So we talked about that already in lecture. That's a problem. And then we have the teeth, that we have a separate model for that. And this one is from your textbook. So when we look at the teeth, top and bottom teeth that have the same teeth in general as far as names, except for the canines on the top. So the first 4 teeth on top and bottom we call the incisors. And if you look at the incisor, it's more flat and made for slicing. So think of when you eat, when you bite a carrot, a hard carrot, you use your incisors to kind of slice that little piece of carrot off. So if you look at a typical incisor, it's kind of pointed and sharp on the edge, and you can feel that with your tongue. So we have central incisors and lateral incisors. So if you look at a rabbit, for example, they have very elongated central incisors, or a mouse or a hamster or a rat. These central ones are extra long. So those are the incisors. And then on either side of that are the canines, and the canines have a little bit of a sharper edge, and they have a little kind of piece on the back of them as well. If you feel with the back of your tongue, the back side base of your incisors, you'll feel a little ridge there. And the incisors are made for tearing. So when we look at canines that are, their main diet is meat, we see enlarged canines for piercing and tearing and of flesh for them to eat. So those are the canines. So find the 4 incisors, and then the next tooth on either side of that are the canines. So here and here. Then we have the molars. So the molars are the flat teeth that we have toward the back of our mouth, and they're more for grinding and working our food down into a, breaking down more large solid bits into a soft, mush. So they're just more for grinding and crushing. That's the molars. And if we look at how many molars there are, we have what's called the premolars and then the molars. The premolars, you can tell, have 2 kind of sharp edges to them. They're a little flatter, but they've got 2 sharp edges. So that's why they're called bicuspids, because of those 2 little pointed pieces. So if you feel just beyond your canines, feel those premolars with your tongue, you can feel those 2 little points on them. So again, they're good for, kind of piercing and grinding our food. And then we have the molars. So beyond that, there are 3 sets of molars, top and bottom. What do we call the back set that doesn't come in until about 17, 16? What? The wisdom teeth, yeah. And some people don't have enough room in their mouth for the wisdom teeth, or they don't come through the gum. They stay below the gum because there's not enough room, and they cause swelling and pain in the back of the mouth. That's called an impacted wisdom teeth. And then some people choose to get those removed if they're impacted or if they're not coming in straight or interfering with, the other teeth in front. And that's a common thing. And they don't come in until, like I say, later in life. And some people feel that is because before we had, hygiene and brushed our teeth, a lot of people lose their teeth, right, as they age. If you never brushed your teeth and never had access to toothpaste or a toothbrush, years ago, at least the wisdom teeth would be there to help eat because they came in, 15 years later than the other teeth. They're also prone to cavities because they're really far back there. And if some of you have a really sensitive gag reflex, that when your toothbrush gets into the back of the mouth, you start to gag. We have that in our family. It's an inherited thing because I've got 6 kids, and some of the kids gag when they brush their teeth and some never do. I never do, but my husband gags every morning. And that would be pretty miserable, I would think, to brush your teeth every morning and be gagging. It's the worst feeling ever. So people don't sometimes get back there and brush like they should, and as a result, they get cavities in the wisdom teeth. So some people just recommend removing them regardless. Okay, so those are the teeth. So in the mouth, we have these salivary glands that produce saliva, and there's the duct that takes the saliva into the mouth. So this large one in front of your ear is called the parotid gland, parotid salivary gland. And you're going to see that on the cadaver. And these glands always have like a cottage cheese appearance in the cadaver and in diagrams and models. So look for that as a gland. So this is the parotid gland. And if you've ever eaten something really sour, you kind of get that ache in the front of your jaw, or in the back of your jaw in front of your ear. That's the parotid salivary gland, just really producing saliva with that kind of acid or really sweet flavoring whatever you've eaten. The mumps is a virus that causes inflammation of the salivary gland. So you see, we vaccinate with the measles, mumps, rubella vaccine when babies are 1. But prior to that, people used to get really big salivary glands and really swollen in their cheeks because of that virus. So we have the parotid salivary gland. We have this, the next one is the sublingual salivary gland underneath the tongue. And then the lowest one underneath the mandible here is the submandibular salivary gland. So you have to know the submandibular and the parotid on the cadaver. You'll see there's an asterisk there. And it's real obvious to see. The parotid is right in front of the ear. It's really large. The other one is much smaller and kind of, you can move it around a little bit, the submandibular. All right, so zeroing in on a tooth itself. So a tooth is a living tissue. Sometimes we think that it's just bone, but it's a living tissue because if we look in the root or in the inside of that tooth, the deep center, there's the living part. So we call that the pulp cavity, is deep inside the tooth. And it contains connective tissue, nerves, and blood vessels. So does it hurt when a tooth is infected or chipped? Yeah, you get down to that pulp cavity where the pulp is. So the pulp is the stuff inside the pulp cavity. Okay, so if you have a really bad, say, cavity that penetrates through the crown and gets into the pulp, in the pulp cavity, it causes pain. And that's when people need a root canal because the cavity is so deep. So what they do is they suck out this pulp, the living part of the tooth, and then they insert just an artificial inert material into that pulp cavity, and then they have to put a crown over the top because that tooth is no longer living and it's subject to cracking and breakdown. Because this is called the crown, the part above the gum line we call the crown. And this layer of white is the hardest substance produced by the body, and that is enamel. Some of us have more enamel than others, so you may notice that you or maybe brothers and sisters or family members, mom or dad, one person in the family has a bunch of cavities and another person in the family hardly has any cavities, and maybe you grew up eating the same foods. But metabolically, your relative, brother, sister, whatever, may have had just a thinner layer of enamel. So they're more at risk for cavities as a result of that. Some people have really thick enamel and don't have any cavities. So that's the white layer here. And we see that only over the crown. So the crown is above the gum, the root is below the gum. So this is the gum, the pink. We call that the gingiva. So when someone has inflammation of the gums due to bacteria that gets trapped underneath here in between the tooth and the gum line, that's called gingivitis. So what's the one thing we can do that's cheap? Probably about $1.99 that you do every day, other than brushing, to get the bacteria between the tooth and the gum line. Floss, yeah. So a sign of gingivitis is when you brush your teeth, if you spit that toothpaste out and you see red in the sink, that's a sign that you have gingivitis, you have infection under the gum, and it's causing bleeding and irritation when you brush those tender gums. So the way to prevent that, start flossing. And you'll be amazed, even after just a week of flossing, how the bleeding will be reduced because you're getting that bacteria out of there. And also a good, oral rinse like the Crest mouthwashes they have are a good idea as well, just to keep that bacteria count down. And then the teeth are not completely hard. They have this soft inside supportive tissue called dentin. So it is hard, but it has a little bit of give. So when you clink your teeth together, heaven forbid, like if you're bouncing a toddler on your lap and then they bounce their head into your jaw and your teeth smack together, you don't crack your teeth because there's a little bit of protection, a little bit of cushion with that blue dentin material. All right, moving on to the next page, page 29. We talked about the upper oral cavity again, just remembering the swallowing process. So you have the oral cavity, then that food goes into the oropharynx here. So remember we have the tonsils there. So this is the oropharynx. Remember the epiglottis here. And then from the epiglottis to the start of the esophagus here is the laryngopharynx. So that's here. So the food goes from the oropharynx to the laryngopharynx and then down into the esophagus from there. So we talked about, or maybe we didn't talk about, but in healthcare, in my healthcare experiences, I've seen a lot more and more of oral cancers, cancers of the throat, and we see those with people who have a history of drinking and or chewing tobacco. So like I said, chewing tobacco is a big thing among young men nowadays, and that habit is resulting in cancers of the pharynx. So it's not good to have those chemicals against those delicate mucous membranes. And we start to see it in the 40s is when people start to develop cancer. So if they started chewing in the teen years, it takes about 20 years for that to turn to cancer, sometimes younger, depending on the kid. I've talked to a friend of mine who worked in a school district where chewing was really popular among the young men, and the school district didn't really do much about it, and kids were chewing it all day during the school day, swallowing it, sometimes even swallowing the tobacco. And as a result, some kids are getting cancers even in the 20s already. Okay, the epiglottis, again, is this cartilage that covers the larynx. It prevents food from going down into the airways, so it, kind of just directs that food down the esophagus. So when we swallow, the larynx rises up, and the epiglottis covers the larynx to prevent us from directing food into our airway. And then we have the start of the esophagus here. So as we go down the digestive tract, then the first, just kind of like a food chute is that esophagus. So if I go into our, go into our Blackboard site, I added a picture here of a digestive model. Here it is. So this is the esophagus here, just a muscular food chute leading into the stomach. So right at the opening to the stomach, we have a sphincter. It's called the lower esophageal sphincter, or it's also called the cardiac sphincter because it's kind of right in the middle of the chest. Well, I shouldn't say that. It's at the bottom of the sternum, but it's pretty close to the chest. So when people have acid reflux and a little bit of that stomach acid comes up and irritates that lower esophageal sphincter or cardiac sphincter, it can cause burning sensation and pressure feelings in the chest. So what are people thinking when they have those sensations? Heart attack, yeah. So that's why it's called the cardiac sphincter, because it's in the center of the chest, kind of near the heart, behind it, right? So it's something that needs to be ruled out right away in the ER. And the way we rule that out is called the GI cocktail, where it's a mixture of lidocaine, which is a numbing agent, and Maalox, which is an antacid, or sodium bicarbonate, I think. Okay, so one of those antacids. So they drink that down, and if their symptoms resolve as a result of drinking that concoction, then we know it's a problem in the digestive tract, in that esophagus, rather than the heart. But if their symptoms persist even after taking the GI cocktail, then we know we got to look at heart stuff. So anytime someone comes in with chest pain, though, we're going to give them an EKG and do cardiac workup right away. But in the meantime, while we're waiting, we can give them that GI cocktail to at least rule that out. So that's the esophagus and the cardiac sphincter. Then we get into the stomach itself here, and there's different regions of the stomach. The cardiac region is this upper region that is, again, right by the cardiac sphincter. So that's the cardiac region. Right, so here's the kind of inside view of the stomach. So the cardiac region is here, just where it meets the sphincter. So this is the cardiac region. Then this is the fundus. The top part of the stomach is the fundus. So this portion here. And then we have the body, which is the main portion of the stomach, which is here. And then we have the pylorus, which is the lower portion right next to the lower sphincter here, which is called the pyloric sphincter. So that's just another muscular passageway, kind of a door that is controlled to allow food to go from the stomach to the small intestines. This is the pyloric sphincter and the pylorus right here. So the body is the central portion, fundus at the top, and the cardiac region here. So the rugae are these wrinkles inside the stomach. And the wrinkles allow the stomach to shrink, decrease in size when it's empty. And as it shrinks, it sends signals to the brain that you're hungry, and you get those hungry sensations when it shrinks like that. And then as we fill it with food and it stretches, that we have sensory receptors on the wall of the stomach that go back to the nervous system that tell you, I'm full. So, okay, so moving on, then we have the inside curvature. The inner curvature of the stomach is the smaller curvature, and then the outside has the greater curvature. So this is the greater curvature and the lesser curvature of the stomach. And then we have the first part of the small intestine. So this is the pyloric sphincter, and this is the first part of the small intestine here, and this is called the duodenum. It's called the duodenum, and that's how that's pronounced. Some people say duodenum, and that's not correct. It's duodenum is how we say that. And there's a lot of digestive activity here. This is the most active part of the digestive tract in terms of secreting enzymes and absorbing, and the other organs putting their contents here. It's an active part of the intestine. And then if we continue down into the rest of the small intestine, so here's the end of the stomach, here's that pyloric sphincter, here's the duodenum, this portion here, and then we have the major portions of the small intestine where a lot of absorption occurs, and that's the jejunum. So all of this central portion of the small intestine is the jejunum. And then the last portion of the small intestine is called the ileum. So by the time we get down to this last portion, most of the nutrients have been absorbed into the blood, and it's starting to just become waste material here at the end of the small intestine, and the bacterial counts go up pretty high. So some people who have had a diseased colon will get their colon removed and have a tube, or not a tube, I'm sorry, a bag right attached to the intestinal wall where the stool comes out of the body. And if the entire colon was removed, you'll see a bag hanging from this portion, and it's called an ileostomy. So it's called an ileostomy, and that's going to be right at the end of the small intestine. And it's liquid stool because the job of the colon is to absorb water, and if it's removed, then the ileostomy contents are going to have a lot more water content than if it was a colostomy at the end of the colon where it's mostly solid. So once the ileum turns into the large intestine, the first large kind of wide portion of the large intestine is called the cecum. And coming off of the cecum is a little finger-like structure called the appendix. And then the intestine moves upward. And this is called the ascending colon. So the valve or passageway from the ileum to the cecum is called the ileocecal valve. And that would be right there between the ileum and the cecum. Ileocecal valve. We have cecum, appendix, and then ascending colon. So as we continue on here, here's another nice view of that ileocecal valve right there. So this is just the large intestine. The small intestine has been removed in this picture. So here's the appendix. So the appendix is an offshoot of the colon. So sometimes it gets packed with stool and becomes inflamed and can't settle down and is in danger of rupturing if it's not dealt with. So what side of the abdomen is the appendix on? So this is your patient laying on a bed. You're looking at the patient in this picture.
On the right.
Yeah, it's on the right side. So we typically see people with appendicitis as having pain in the middle, lower part of the abdomen, or off to the right, because that's where it is. And a good way to test for appendicitis is have the person stand on their tiptoes and then drop hard to their heels. And if that causes pain in that area, then that's a sign of appendicitis. Another one is you press on this region and then you release, and if that causes pain, that's another sign of appendicitis. So oftentimes kids complain of belly pain, and I've had that issue with my kids and friends' kids, and sometimes it's just constipation and gas as it stretches the colon and they haven't gone number 2 in a while. That causes pain in the abdomen. But appendicitis is pretty specific, so you want to rule that out before. You don't want to have your kids going in for CT scans all the time looking for appendicitis. You want to kind of be sure. And oftentimes they'll do an abdominal x-ray and they'll just see a bunch of stool in there and say, ah, he's backed up or she's backed up, and they'll give you something to correct that. But we tend to eat a low-fiber diet, not drink enough water as a society. So to help keep the stools moving, it's really important that we drink water and have fiber in our diet. And the typical young person's diet of mac and cheese, pasta, pizza, burgers, you know, those are not foods that are high in fiber, and it tends to cause people to be constipated. So drinking water is really important, and exercise is really important for getting smooth muscle to get moving. So our patients, if we want them to feel better, sitting around eating the mushy comfort foods on the hospital menu are not going to help them get moving. So a kind of a rule of thumb is if it goes in hard, like salad, carrots, apples, your stool will come out soft. If it goes in mushy, like soups and potatoes and macaroni and cheese, burgers, it's going to come out hard because those are not high fiber items. So increasing our water can make a big difference, just drinking more water. And I see water bottles and coffee too. We know coffee is a stimulant of smooth muscle contraction. Some people rely on that to get their bowels moving in the morning. So some patients, you know, if coffee is part of their routine, offer them that coffee. Every unit typically has coffee available. Okay, so we have ascending colon, then we come across, we have transverse colon, then descending colon. So there's 2 little turning points here in the large intestine. And ascending, where it turns here, this is the right side of our patient, right? So it's called the right colic flexure. A flexure, to flex is to bend, right? So a flexure is where it bends. Right colic flexure. The liver is also on the right side. So another name for this bend is called the hepatic flexure. Then as it comes across on this side, this is the left colic flexure, but the spleen is located here as well, so we call it the splenic flexure. So whatever you want to call it, left colic, right colic, referring to colon, right? So you've heard of babies having colic, right? So that means they have gas in the large intestine because of an inability maybe to break down the proteins in milk or the sugars in milk, and then they end up with sharp abdominal pains. Descending colon then comes down, and then we have this curve here. This is the sigmoid colon. So this is where stool sits the longest. So the problem with the American diet, because it's low fiber, high preservative, low water, is stool sits in the sigmoid colon longer than it should be. And all those preservatives and high fat is not good for the mucosa again, right? So anytime we talk about, you know, artificial things or unhealthy contents up against mucosa, we're increasing the risk for cancer. Yeah. So oftentimes colon cancer is a big problem here in the US, right? And that colon cancer is oftentimes in the descending or sigmoid colon or in the rectum, right? Colorectal cancer, because the stool sits there and causes irregular growth of that mucosal wall. So again, keeping our stool moving through the system is a good idea, so it's not sitting there for a long time. So stool sits here and then eventually works its way into the rectum. So this portion here, before it narrows to become the anal canal and the anal sphincter, it's called the rectum. So this is where we feel the urge to have a bowel movement, is when that stool moves into the rectum. So if a patient has a sluggish bowel and the stool is sitting all in here, or a child, boys particularly are at risk. Boys from ages about 3 to 12 have a high risk for constipation issues, because what do the bathrooms look like in typical elementary schools? Do they have closed doors for kids to have bowel movements? Some of them do, some don't. How do boys act in elementary school when the guys in here, when it comes time to have a bowel movement? Do they give each other a break and let them have bowel movement in the elementary schools? No, they jump on the stalls, right? They look down, they tease kids for having a bowel movement, right? Because nobody has bowel movements, right? I mean, that's ridiculous. But it's a real problem. So kids hold it all day. They have these, you know, big lunches. They hold it all day, and then they set themselves up for constipation, because we see this in the nursing home too. Soft, mushy nursing home food, lack of activity, laying around, maybe taking pain meds because of arthritis or other issues. The bowel gets stretched. So stool sits in the sigmoid colon and works its way up the descending, but it doesn't enter the rectum, and as a result of that, it gets sluggish and it doesn't contract like it should anymore. So they're not able to even have a bowel movement because they're so stretched out. Sometimes the stool gets stuck in the rectum too, and there's no way of getting it out. So probably the worst part of nursing is when you have to go in and digitally, you know, go into the rectum and get that stool out of there and stimulate the walls of the rectum to get a bowel movement going. That can be a real mess. But it's important, again, it's not pleasant to do, obviously, but by doing that, we're keeping our patients healthy by keeping the tract moving and not just letting stuff sit there. So the anal canal here is where it narrows, and then the very end is the anal sphincter. So in the model, if he has the pin at the very end, it's anal sphincter. All right, then we have the accessory organs. So food does not pass through the accessory organs. They just have a digestive function. So the liver has lots of functions, but the digestive function of the liver is to make bile, which means secretes this substance, this greenish, yellowish substance, to the hepatic duct, then to the common bile duct, which goes into the duodenum here. This is a piece of the small intestine in the beginning. So we have the hepatic ducts here that come from the liver that makes most of the bile. Then it comes down and joins the common bile duct, the green, going into the duodenum. And bile is important for breaking down fat. We need bile to break down fat in our digestive tract. So this is the gallbladder that's tucked up underneath the liver, and it has a little duct as well, and this is called the cystic duct. And again, combines to form the common bile duct. So the cystic duct and the hepatic ducts come together to form the common bile duct. So the job of the liver and the gallbladder is to release bile. But the gallbladder only stores the bile. So it doesn't make the bile, it just stores it. About 30% of the bile produced by the liver is stored in the gallbladder. Most of it comes from the liver. So can we survive without our gallbladder then? We can. We're not going to be as good at breaking down fatty substances. So people that have had their gallbladder removed might find that they get a little digestive upset when they eat fattier foods, but they do okay. So the number one risk factor for gallbladder removal is being overweight, most of the adult life, being female, and being over 40. Those three combinations are major risk factors. Most gallbladder patients fit that profile. But there are young people that are not overweight, that are male, that have had gallbladder issues. So it doesn't mean everybody else is exempt. It just means the most common patient is that. But there are definitely younger people that have issues with gallbladder. And because it's in charge of breaking down fat, other people that are at risk for this are women that have just had a baby. Their cholesterol levels can be kind of disrupted because of pregnancy, so they are at risk for gallbladder issues. And people that have done rapid dieting, so they're breaking down that fat, it's entering the bloodstream, and puts them at risk for gallstones. So you get hard calcifications that blocks the ducts here and causes pain, and they have to remove the gallbladder. Then we have the pancreas. Its job is to make digestive enzymes. We know the pancreas is important for insulin and glucagon, but that's an endocrine function, it's not a digestive function. So what it does for the digestive tract is makes digestive enzymes and releases those to the pancreatic duct, which then comes in and releases that into the duodenum. So this is the pancreatic duct and the pancreas, which produces digestive enzymes. So the pancreas is on the left-hand side. And the digestive tract has a special blood supply that it has blood vessels that go from the digestive tract through the liver and then to the rest of the body. So people with pancreatic cancer, because this is an organ that doesn't have a lot of sensory receptors, it can go undiagnosed for a while until it's spread throughout the body, and people don't live very long when they have pancreatic cancer because the blood from the digestive tract passes through the liver and then they end up with cancer and tumors in the liver, which causes huge problems. So pancreatic cancer is a very serious cancer that takes people's lives quickly. All right, so I think that covers everything. I want to just quickly go through the model here so you can recognize some of the structures in this model I put on Blackboard. So again, we have the jejunum, right, is the main portion. Can I make this bigger? No. So we have the jejunum, we have the duodenum. Well, I'll start from the top. We have the esophagus, the stomach, pyloric sphincter. The duodenum is this portion here. The pancreas is underneath the stomach here. We have the jejunum, all of this here. So he'll usually put a pin right in the center. And then the ileum is this last portion. And then the ileocecal valve is right here. And then we have the cecum, the appendix, this gray kind of offshoot, ascending. And we have the right colic flexure, transverse colon coming across. Then we have the left colic flexure. There's the spleen, but that's not part of the digestive system, so you don't need to know that. Then we come down here on the outside, descending colon, sigmoid colon. This is the rectum here. This wider portion where it narrows is the anal canal. And then the last part is the anal sphincter. Then in the liver, we can see the liver here, and then that green structure tucked underneath it is the gallbladder. So be sure to put some of these models out to look around at those. And then we have some structures on the cadaver that Deke will give you a little tour of here, or I'll put some pictures on Blackboard from one of our atlases. And that concludes the lab on the digestive system.